Hello and welcome to the topic Pulmonary Hypertension in the Respiratory module. By the end of this topic, you should be able to define pulmonary hypertension, discuss the epidemiology of this disease, outline the pathophysiology and causes of pulmonary hypertension, outline the classification of pulmonary hypertension, describe the clinical manifestations of pulmonary hypertension, outline the investigations that are carried out for this disease, and discuss the principles of management as well as complications of pulmonary hypertension. Let's get started. Pulmonary hypertension is defined as a sustained elevation in the mean pulmonary arterial pressure of more than 25 mm mercury at rest or more than 30 mm mercury during exercise. It is a relatively rare disease with the incidence of 2.4 cases per million adults per year, but can be life-threatening. Women are more commonly affected with a male to female ratio of 1 to 3.9, and the mean age of diagnosis is in the 50s. Although it can affect all races, a study in the US suggests a white predominance. With the advancement in pharmacotherapies, the prognosis and the survival rate of the disease has improved along the years. So let's take a look at how pulmonary hypertension occurs. First, we need to understand the physiology of the pulmonary circulation. The function of the pulmonary circulation is to carry deoxygenated blood from the systemic circulation to the lungs for gaseous exchange. When deoxygenated blood from the superior and inferior vena cava returns to the heart, it passes the right atrium and then the tricuspid valve reaching the right ventricle. The right ventricle then contracts, pushing the blood through the pulmonary valve into the pulmonary trunk. The pulmonary trunk divides into the left and right main pulmonary arteries and branches into small arterioles. The blood eventually reaches the capillaries at the alveoli, which are the sites of gaseous exchange. Then, the freshly oxygenated blood returns to the heart through pulmonary venules, pulmonary veins, and finally reaches the left atrium. From here, the blood is ready to be pumped to the systemic circulation via contraction of the left ventricle. Although the pulmonary circulation is phased with the entire cardiac output, the abundance of small pulmonary capillaries with high cross-sectional area help maintain a low-pressure system. Besides, the pulmonary arteries have thin walls with high compliance and less muscular layer, allowing them to carry more blood. The pulmonary vascular resistance is affected by various passive and active factors. A low pulmonary vascular resistance maximizes the blood distribution to peripheral alveoli for optimum gaseous exchange. The pulmonary vasculature runs in a parallel manner rather than in series, further reducing the resistance. There are several vasoactive compounds that can affect the pulmonary vascular resistance. Prostacyclin and nitric oxide serve as vasodilators, while endothelin is a vasoconstrictor. The endothelin is a potent and long-acting vasoconstrictor. It is secreted as a prohormone by the vascular endothelium and is converted to endothelium-1 by endothelin-converting enzyme. It is believed that endothelin system is important in the pathogenesis of many diseases such as primary pulmonary hypertension, cardiac failure, hepatorenal syndrome, and Raynaud's phenomenon. According to the Poiseuille equation, the pulmonary vascular resistance is directly proportional to the length of the blood vessel and viscosity of the blood and indirectly proportional to the radius of the blood vessel to the fourth power. Hence, a small reduction in the radius of the blood vessels can lead to a dramatic increase in pulmonary vascular resistance. The increase in pulmonary vascular resistance is the main pathogenic mechanism in pulmonary arterial hypertension. Endothelial dysfunction causes disorganized endothelial cell proliferation, decreasing the production of vasodilators and overexpression of vasoconstrictions such as endothelin. On pathology, patients with pulmonary hypertension are found to have hyperplasia and hypertrophy of the intima, media, and adventitia of the pulmonary arterial vasculature. These changes suggest the predominance of thrombogenic, mitogenic, pro-inflammatory, and vasoconstrictive factors as a consequence of endothelial dysfunction. In the long run, the right ventricular overload leads to right ventricular failure and eventually death. The causes of pulmonary hypertension can be divided into 5 groups on the basis of similarities in pathophysiology, clinical presentation, and therapeutic options. Group 1 is known as pulmonary arterial hypertension or PAH. It includes idiopathic and familial pulmonary hypertension as well as persistent pulmonary hypertension of the newborn. It is commonly associated with collagen vascular disease, congenital heart disease with systemic to pulmonary shunts, HIV, and sickle cell disease. Group 2 is pulmonary hypertension with left heart disease. The causes include left-sided atrial, ventricular, or valvular diseases such as left ventricular, systolic, and diastolic dysfunction, mitral stenosis, and mitral regurgitation. Group 3 is pulmonary hypertension secondary to lung disease or hypoxia. Chronic obstructive pulmonary disease COPD, interstitial lung disease ILD, sleep apnea, and high altitude are some of the causes. Group 4 includes pulmonary hypertension due to thromboembolic disease, and Group 5 is caused by miscellaneous conditions such as lymphangiomatosis secondary to carcinomatosis or sarcoidosis. There is a classification for the assessment of functional status of patients with pulmonary hypertension created by the World Health Organization. Class 1 describes that there is no limitation to physical activity. Class 2 is for those with slight limitation of physical activity, and when patients have marked limitation of physical activity but still comfortable at rest, they are labeled as Class 3, and Class 4 is reserved for patients who cannot carry out any physical activity without symptoms. The clinical manifestations of pulmonary hypertension are frequently masked by the underlying disease entities. Exertional dyspnea is one of the most common symptoms patients experience. Other than that, they may also complain of non-specific symptoms such as fatigue and anorexia. In severe cases, patients also experience chest pain and syncope with exertion. What are the clinical signs that can suggest pulmonary hypertension? The cardiovascular and respiratory examination are the two most important examinations for pulmonary hypertension. Patients can have right ventricular heave upon palpation, which suggests the presence of right ventricular hypertrophy. The intensity of the pulmonic component of the second heart sound may also be increased due to the delayed closure of the pulmonic valve. Sometimes, a hollow systolic murmur, best heard at the left sternal border, suggesting tricuspid regurgitation can be heard. If complicated with heart failure, patients can develop hepatomegaly, pulsatile liver with ascites, peripheral edema, and distended jugular veins can be seen. Besides that, the signs of underlying causes, such as those from collagen vascular diseases, should be looked out for. How do we diagnose pulmonary hypertension? Findings from the history, physical examination, and other simple tests may suggest the presence of pulmonary hypertension and right ventricular dysfunction. Ultimately, a right-sided cardiac catheterization serves as the confirmatory test for pulmonary hypertension, as it can measure pulmonary arterial pressure accurately. As it is a relatively invasive test, non-invasive tests should be performed first. An electrocardiography or ECG can show right axis deviation, R to S wave ratio more than 1 in lead V1, increased P wave amplitude, and right bundle branch block or RBBB. Besides, we may find increased thickness of right ventricular wall, right ventricular dilatation, presence of tricuspid regurgitation jet, and estimate the pulmonary arterial pressure using the Doppler echocardiography. A chest X-ray may show enlarged main pulmonary arteries with attenuation of periphery vessels and right atrial dilatation. Another special test for pulmonary hypertension is the vasoreactivity test, which has treatment implications. It can help identify candidates for calcium channel blocker treatment. It is done by administering short-acting vasodilator and measure the pulmonary arterial pressure. A positive acute vasodilator response is represented by the fall in mean pulmonary artery pressure of more than 10 mm mercury to a value less than 40 mm mercury with an increased or unchanged cardiac output. To investigate for the causes of pulmonary hypertension, a lung function test can be helpful to check the presence of obstructive and restrictive pattern to rule out COPD and ILD. Other than that, if pulmonary embolism is suspected, a CT pulmonary angiography or a ventilation perfusion scan may be ordered. If patients complain of snoring problems, sleep studies can be used to exclude obstructive sleep apnea. Other than that, autoantibody panels including antinuclear antibodies, rheumatoid factor, and anti-neutrophil cytoplasmic antibody or ANCA can be used to screen for collagen vascular diseases. Management of pulmonary hypertension consists of supportive therapy as well as advanced vasodilatory therapy. Effective therapy should be administered in the early stages where the irreversible changes in pulmonary vasculature is yet to occur. Supportive therapy includes oxygen therapy, diuretics, digoxin, exercise, and anticoagulation. Decisions to start each of these therapies should be made on a case-by-case basis in the appropriate clinical scenario. Patients with a positive reactivity test are offered calcium channel blockers. However, most of the time, only a small minority of patients are vasoreactive and thus candidates for calcium channel blocker therapy. The advanced vasodilatory therapies are largely confined to cases of WHO Group 1 pulmonary arterial hypertension. Guidelines recommend against using these advanced therapies in Group 2 and Group 3. And initiation of this should be in specialized centers by providers experienced in treating pulmonary hypertension. There are three main classes of therapy, each targeting different pathways. The endothelin receptor antagonists such as ambrisentan, bosentan, and macitentan blocks the endothelin, which is the vasoconstrictor. The phosphodiesterase 5 inhibitors such as sildenafil, tadalafil, vardenafil, and guanylate cyclase stimulators such as riociguat results in vasodilation through the nitric oxide pathway. The prostacyclin analogs such as beroprost, iloprost, and prostacyclin receptor agonists such as selizibec also results in vasodilation. These vasodilatory medications commonly cause headaches. For patients with functional class 2 or 3, a combination of two agents with separate pathways should be started. In severe cases, lung transplantation should be considered. Besides giving pharmacotherapies, patients should be encouraged to remain active. This is to prevent deconditioning and increase functional capacity of the patients. Patients should also be advised to abstain from smoking. Influenza and pneumococcal vaccination have also been shown to reduce risk of pneumonia, which represent 7% cause of death of pulmonary hypertension. So what are the complications of pulmonary hypertension? The most common and feared complication is right heart failure. Progression to right heart failure is part of the natural history of pulmonary hypertension and is often present to some degree at the time of diagnosis. Other less common complications include pulmonary artery dissection, massive hemoptysis, and left main compression syndrome, where the left main coronary artery is compressed by the pulmonary artery trunk. Supraventricular tachyarrhythmias may also occur, presumably triggered by right heart disease. In summary, pulmonary hypertension is defined as a sustained elevation of the mean pulmonary arterial pressure of more than 25 mm mercury at rest. It is a relatively rare disease with women predominance. The causes are categorized into WHO groups. The pathophysiology revolves around endothelial dysfunction leading to changes in vasodilators and vasoconstrictors. Presentation is exertional dyspnea, fatigue, and syncope. Clinical signs include loud P2, right ventricular heave, tricuspid regurgitation murmur. A right heart catheterization is required for confirmation of diagnosis. Management is mainly supportive, and WHO Group 1 can be treated with vasodilatory therapies. The most common complication is right heart failure. So we have come to the end of this topic. Thank you.